None of the producers have any financial interest in the products or procedures shown. IOL drop. A dropped IOL does happen to every cataract surgeon at some point of time or other. It is therefore important to know how these may be handled. Very often, these IOLs descend onto the retina, though sometimes they may still be found in the anterior or mid-vitreous. It is important to know how to manage these IOLs. An IOL drop can occur intraoperatively due to sudden uncontrolled injection or secondary to unstable implantation. A pars plana vitrectomy is therefore often required. A wide field lens may be used for panoramic visualization. A diamond-tipped forceps or microforceps may be used to pick up these IOLs. It is important to free the IOL of all vitreous adhesions before lifting it up. Grasping the lens over the disc prevents iatrogenic retinal tears. The supramacular lens provides a zoomed-up view and superior three-dimensionality. Chandelier illumination from a light source attached to the infusion cannula or via a separate port gives uniform illumination, while at the same time freeing the left hand for bimanual vitrectomy. Xenon light source is brighter than both dual output halogen and dual output metal halide light sources. Single piece IOL should be brought up with extra care into the AC for fear of haptic cracking, as happens in this case. The IOL was placed temporarily on the iris before retrieving the haptic. A broken haptic with a sharp tearing edge is more challenging to lift, and achieving good visualization and three-dimensionality is critical. Once both were retrieved, they were explanted through a corneoscleral section. A technique that we now use for dropped IOLs utilizes a sleeveless extrusion cannula. The IOL can thus be safely grasped from anywhere on the retina and need not be moved over the disc. The extrusion cannula is applied to the center of the optic and suction is used to hold and lift the IOL. This gives advantages of safety and ease. The extrusion cannula technique helps in safely picking up an IOL without causing any collateral retinal damage. Forceps may touch the retina while picking up an IOL and cause retinal tears or retinal hemorrhage. These disadvantages are avoided by the extrusion cannula technique. It is important to grasp the IOL with a forceps after bringing it to mid-vitreous and subsequently explant it using the forceps. Attempting to lift it into the AC and explant using the extrusion cannula can lead to loss of suction and a redrop. An overly short section is always a predisposing factor for nucleus drop, and rarely a dropped IOL with a dropped nucleus may be seen. SPAL or sleeveless phaco-tip assisted levitation is a technique that we use for bringing up these nuclei. Soft, intumescent nuclei may be removed using the vitrector probe. The sleeveless extrusion cannula is then used for lifting the IOL. Many of the eyes with dropped IOL do not have sufficient capsular support. Insufficient capsular support being the primary cause of many of these dropped IOLs, a secondary fixation of the IOL is often required in the form of a glued IOL or an iris-fixated IOL. A situation sometimes encountered is a dangling or dislocated IOL bag complex. Pupillary dilatation with iris hooks is often required for explanting the entire bag IOL complex, followed by secondary IOL fixation. A dropped three-piece IOL may be managed simply by a closed chamber translocation of the dropped IOL into a glued IOL. This gives the advantages of speed and ease of surgery. A one-piece non-foldable IOL may also be similarly translocated, taking care not to crack the haptic. The handshake technique may be used effectively for grasping the extreme tip of haptic prior to exteriorization. closed chamber translocation, however, cannot be done for plate haptic IOLs or for single-piece foldable IOLs. Sometimes a surgeon may face an IOL drop while attempting to explant the IOL, as seen in this case with AC-IOL and dropped nucleus. The haptics of the AC-IOL fibrosed to the iris were cut for explantation. However, the IOL drops, and we are now faced with a dropped nucleus and a dropped IOL. Shallowing the anterior chamber floated the IOL and nucleus upwards, and the nucleus was removed. The IOL was then explanted using the sleeveless extrusion cannula. A glued IOL and eyelidoplasty were done. A rare scenario is the placement of two IOLs in the eye. Here is a case of a dislocated PC-IOL lying behind an AC-IOL. Vigorous attempts to remove single-piece PMMA IOLs can lead to haptic breakage. A better option here would have been to explant the AC-IOL followed by the dislocated PC-IOL. Despite a limited view, the handshake technique is very helpful for closed chamber fixation of the post-operative dislocated IOL into a glued IOL. PFCL may be used for floating up a dropped IOL. Formation of small bubbles should be avoided while injecting PFCL. Incomplete PFCL removal may rarely cause other complications. A dropped CTR may also be lifted out of the vitreous cavity bimanually using the handshake technique. A CTR lying in the anterior vitreous may be entangled with the IOL and should be carefully disentangled before explantation. Blunt injury in a pseudophakic eye generally leads to a wound gape and dislocated IOL. Though closed chamber translocation of a single-piece PMMA IOL may be done, the chances of haptic breakage are much higher and may need to be replaced by a three-piece IOL. With adequate sulcus, the retrieved IOL can be placed in the sulcus. This may be done with ease using the handshake technique. To conclude, any vitreoretinal procedure requires intervention by a trained specialist, and referral is often indicated and should be done for such cases. If not managed properly, a dropped IOL can cause problems like inflammation, hemorrhage, cystoid macular edema, retinal tears, etc. However, the anterior segment surgeon should be aware of the various management options in such complicated cases, and that is exactly what this video aims to do.